This conference will now be recorded.
So today we are going to discuss another TOG article from January 2021. This ovarian cystectomy pose a risk to ovarian reserve and fertility. So in this TOG article, basically what they have discussed is what is the effect of various types of ovarian cyst on the fertility and ovarian reserve. And finally, they have given the what are the different methods of ovarian cystectomy and how they have effect on this ovarian reserves, and what is the ideal way to do the ovarian cystectomy. So what are the surgical recommendations for doing ovarian cystectomy? So these all the things they have discussed in this TOG article. So we'll come to one by one to those. So first, the most common ovarian cyst, that is functional cyst, functional ovarian cyst and their effects on fertility. So functional ovarian cyst, as you all know, these are the non-pathological follicular cysts that fail to ovulate, or persistent corpus luteum cyst, or other unspecified ovarian cysts which are more than 20 millimeter in diameter. And these are most common ovarian cysts in adult and children, and they account for total 46 to 53% of all adnexal pathologies. They usually regress spontaneously within 1 to 3 menstrual cycles, and they should not require any surgical or hormonal interventions. So no ossicles also, or no surgery for this functional ovarian cyst. Corpus luteal cysts, they are observed in 10% of natural menstrual cycles in fertile women, but what they have found out that they are common in infertile population. So when they have done one study, they have found that corpus luteal cysts, they occurred in 25% of IUI cycles in women with unexplained infertility. So now what are the effects of this cyst on the fertility potential? So the women who have already low ovarian reserve and those on gonadotropin releasing hormone agonist, that is GnRH agonist cycle, they are at increased risk of developing functional cyst. And the patients who are undergoing this ovarian stimulation, incidence of this persistent functional cyst is between 8 to 53%. But what is the effect on this of the cyst on IVF? It remains contentious. Still, it is not properly described. Some studies, they suggest that very poor outcome of cycle because of high cancellation rate, decreased follicular recruitment, and low pregnancy rate. While other studies, they have failed to report such problems. So still we don't have a proper evidence that this cyst impair the fertility in IVF cycles. But if these cycles, if the cysts are present during ART, the first line of treatment is usually prolonged downregulation with either progesterone only pill or ossicles, combined ossicles. And as a last resort, you can go for either ultrasound or laparoscopy guided drainage. So this functional cyst, usually they don't have any effect on fertility, but they are more commonly occur in the infertile patients. Now coming to the dermoid cyst. So dermoid cyst, it is a benign germ cell tumor which arises from totipotent ovarian cell. These are the most common pathological cysts in premenopausal women. So functional cysts, these are the most common cysts, but we don't call it as a pathological cyst. So the most common pathological cyst in premenopausal women is dermoid cyst. They are bilateral in 10 to 20% of cases. They grow. So the rate of growth is 1.7 to 1.8 millimeter per year. Recurrence rate is 3 to 4% after the cystectomy. Usually this dermoid cyst, it doesn't have, or it will have a very little effect on fertility. But what happens is this dermoid cyst, they usually occur bilaterally and they have high recurrence rate and they can grow to a large size. Okay, so these require surgeries. So because of these surgeries or bilateral procedures or cystectomies for large cysts, they are at risk of causing decreased ovarian reserve or adverse effect on fertility. So dermoid cyst as per se, they doesn't have any effect on fertility, but because of they require surgeries frequently or recurrent surgeries, they may have the effect on fertility rate, that is the adverse fertility outcome. So In one study, what they have showed that there is a statistically significant reduction in AMH if the cyst is, so the operated cyst is more than 5 centimeter in diameter. So if the cystectomy is done for more than 5 centimeters of cyst, the AMH levels will be decreased after the surgery. So what they have advised is you have to operate on the dermoid cyst early while the cyst is very small. So it will prevent the need of large cystectomy and lower the effect on ovarian reserve. So here the conclusion is dermoid cyst per se doesn't have any effect on fertility, but because of cystectomy, it may lead to decrease ovarian reserve and decrease AMH. So you should operate it at earlier. Coming to the hemorrhagic cyst. So hemorrhagic cyst, it is the result of bleeding into the follicle or corpus luteal cyst. They will also resolve mostly spontaneously, but sometimes they can become trapped by pelvic adhesions. On ultrasound imaging and on laparoscopy, they usually appear. So it is very difficult to differentiate endometriotic cyst from this hemorrhagic cyst. And the diagnosis is only confirmed by histology. So same thing like functional cyst, hemorrhagic cyst, it doesn't have any effect on fertility. But if you go for cystectomy of this hemorrhagic cyst, again, there is risk of compromising ovarian reserves. Now, this is the most important thing, what is they have discussed in the talk in more detail regarding this endometriomas. So endometriomas and considering endometriomas and their effects on fertility. So these endometriomas, they are reported in 17 to 44% of women with endometriosis, and it is a feature of severe and deeper disease. 28% of endometriomas, they are bilateral. The risk of recurrence of endometriomas in the same ovary or other ovary following surgery is high. So cumulative recurrence rate is 12 to 30% at 2 to 5 years of follow-up. And most recurrences, they occur in the same ovary, that is the ovary which has undergone cystectomy. So it suggests that the cyst will grow from this residual loci of this endometriotic focuses. Okay. So the mean monthly rate of growth of endometriomas following post-operative recurrence is about 0.48 centimeters who are not using any hormonal therapies. So recurrence rate with growth rate is 0.48 centimeter per year. Now we all know that endometrioma is associated with poor fertility outcome. So what are the reasons for this is? Usually because of chronic inflammation, it affects the oocyte quality and also causes impaired ovarian function, which will result in defective folliculogenesis and defective fertilization. Poor embryo quality secondary to altered follicular environment, which will result in embryos with reduced implantation capacity. Poor ovarian reserve because of significant reduction in primordial follicular cohort, because of fibrosis from this oxidative stress, or because of surgery also. Anatomical distortion and tubal damage or occlusion, tubal occlusion. So there will be distorted because of repeated surgeries or because of this endometriomas. They will have this deep pelvic adhesions and it will cause anatomical damage or anatomical distortion. And the endometriomas, in women who have endometriomas, they are known to have lower AMH levels and antral follicular counts compared to their age-matched controls. So these are the all reasons for poor fertility outcome in women with endometriomas. So till now we have discussed functional ovarian cyst, hemorrhagic ovarian cyst, dermoid cyst, and endometriomas. Now, what are the other ovarian cysts, other benign ovarian cysts and their effects on fertility? So, other benign ovarian cyst common we know is ovarian cystadenoma, either serous or mucinous. Okay, so serous and mucinous benign cystadenomas, they are the most common benign epithelial neoplasms. Of that serous cystadenoma, they usually arise in menopausal women. It is more prevalent in menopausal women, serous. While mucinous cystadenoma, it occurs at earlier age and it in reproductive age women. And they grow to a very large size. These mucinous cystadenomas, you also know they grow to a very large size. And There is a greater chance of oophorectomy because of this multilocular nature of this mucinous cyst adenomas. Also, surgical peel of this mucinous material, it will lead to pelvic adhesions and subsequent infertility. So the mucinous cyst adenoma surgery, it may be associated with this decreased ovarian reserve or decreased fertility potential. Now coming to the benign cyst in children and adolescent. So oophorectomy, it is frequently performed in this children and adolescent group. 75% of oophorectomies, according to one study, what they have found out is 75% of oophorectomies in children and adolescents are carried for benign ovarian cyst. Functional ovarian cysts, they account for almost 45% of all pediatric adnexal abnormalities, and they usually resolve spontaneously. Then after that, next more common tumor is teratoma. Teratoma means it can be immature or mature teratoma. So mature teratoma is more common, and 1% is immature or malignant teratomas. Now, as you know, in adult or in reproductive age group woman, for any ovarian cyst, when the patient is for surgical management, the choice of surgery is laparoscopic cystectomy in reproductive age group woman, and this is the same practice which should be followed in children and adolescents also. But here you have to be very cautious because you should be using this pre-operative investigations like ultrasound and MRI and tumor markers, and along with multidisciplinary team approach to diagnose the cyst, okay, to diagnose the type of cyst, because functional cyst you can give conservative management, and only complex ovarian cyst, if they are symptomatic enough, you will be going for surgery. So if you use all these modalities wisely, you can go for conservative surgery or conservative management also. So here you can better protect the future fertility in these individuals. Now coming to the ovarian torsion and its effect on fertility. So approximately 3% of all emergency gynecological surgeries, they are for ovarian torsion. Cumulative incidence of ovarian torsion in women with ovarian cyst or ovarian tumor is 0.3%. The torsion usually involves ovary and fallopian tube simultaneously, and it is more commonly seen with benign cyst more than 5 cm diameter. Conservative management is the mainstay of treatment, that is laparoscopic untwisting of the twisted ovary. It is the treatment of choice in prepubescent girl and women of reproductive age, regardless of color of ovary at the time of surgery. Now, this is the question which is almost asked by every alternate exam. Okay, so whether the ovary looks necrotic, whether the ovary is blue, black in color, whatever is the color of the ovary, you will be just untwisting the ovary. Okay. So in cases where the torsion has occurred in presence of ovarian cyst, you can go for elective cystectomy 2 to 3 weeks later to allow the time for the congestion and edema to resolve. Because cystectomy, if you do with this distorted ovary, there is more chance that you will strip the cyst off. Okay, you will strip off the cyst, and in that you may also remove the normal ovarian tissue also. So it is better to do only untwisting and go for this cystectomy 2 to 3 weeks later. Detorsion of this ischemic ovary, it preserved ovarian function in 91.3% of patients. So whatever is the color of ovary or however necrotic it looks, the ovarian function is preserved in 91% of these patients. So ovarian cystectomy. So now till now we have seen what are the different types of ovarian cyst and its effect on the fertility. Now, if you are doing ovarian cystectomy, so then what are its effect on the ovarian reserve? So this effect on this ovarian reserve, it depends upon size and nature of the cyst being removed, bilaterality or repeated surgery, methods of cystectomy and methods of hemostasis what you have used, the skill and experience of the surgeon. So these are all important factors which determine how much of that effect will be on the ovarian reserve. Now, how to do this ovarian reserve assessment? So AFC assessment is likely to be less reliable in presence of endometriomas because sometimes because of large endometriomas, it is very difficult to count AFC, so it is less reliable. If you go for stripping and removing the cyst wall or the thermal damage which is used by this coagulation, it can lead to loss of healthy ovarian tissue and subsequent reduction in the follicular density. The more significant decline in ovarian reserve, it is observed following removal of endometriomas, which has a size more than 5 to 7 centimeter. So it is always wiser to proceed with surgery when the cyst is small, especially in those patients with mucinous cystadenoma, which has a propensity to go into larger cyst. Also, bilateral cystectomy, it can lead to a greater decline in the ovarian reserve than unilateral surgery. In particular, women who have surgery for bilateral endometriomas, they have shown to have increased risk of premature ovarian insufficiency. Now, when you consider ovarian cystectomy and its effect on spontaneous conception, so now we have to divide between the two, that is spontaneous conception and ARTs. So high rates of spontaneous conception, it has been shown in infertile women who had surgical treatment for endometriomas. So what they have done, they have divided this endometriotic cyst woman into two groups. One is women with subfertility and women with in those they don't have this proven subfertility or infertility. So spontaneous conception, it has higher rates if you do surgery, endometrioma surgery in infertile women. But it is difficult to recommend routine surgical treatment to improve the chances of conception in those without proven infertility. So if it is an incidental finding of ovarian endometrioma and patient doesn't have a history of subfertility, it is not wise to recommend routine surgical treatment for this endometriomas. Also, even the infertile woman with this endometrioma, potential benefit of improving her chances of spontaneous conception through surgical management, it must be balanced with risk of reducing her ovarian reserve and worsening pelvic anatomy. So what Ishri recommends is, Ishri recommends that clinician should counsel the woman about the risk of reduction in ovarian reserve along with possible loss of entire ovary. So whenever you are doing pre-operative counseling, you have to tell the reduction in the risk of reduction in ovarian reserve and also possible need of oophorectomy. Okay, in particular, those who had previous ovarian surgeries. So now for which patient ovarian cystectomy is preferred and which patient conservative management is preferred in case of endometriomas. So the thing what they have recommended is cystectomy for endometriomas prior to IVF is not routinely recommended because it has not been shown to improve IVF outcomes. So surgery for endometrioma recommended only for the patient who has proven infertility and it will increase the rate of spontaneous conception, but not for IVF patient or not for the patient who doesn't have a history of infertility or subfertility. Now, which are the factors which favor surgery for endometrioma? So if she doesn't had any previous interventions or previous surgery for endometriosis, if her ovarian reserve is intact, if she has pain symptoms and she doesn't have any bilateral disease, that means only unilateral cyst, and suspicious features of malignancy are present or the cyst is having rapid growth. So all these features suggest that she should undergo the surgery. While if she had undergone any previous surgery for endometriosis, her ovarian reserve is already damaged, she doesn't have pain symptom right now, or she has bilateral endometriomas, no sonographic features of malignancy and stable growth, this patient should be managed with expectant management. So now coming to the surgical technique. So surgical technique of this ovarian cystectomy on fertility outcome. So cystectomy is always superior to the drainage and molecular coagulation in terms of spontaneous pregnancy rates, lower the rate of recurrence and pain symptoms in subfertile patient with endometriomas greater than 3 centimeter. Better preservation of ovarian reserve if you use this laser ablation or plasma energy rather than cystectomy. But the recurrence rate after this laser ablation, they are higher. Now, using thermal energy or bipolar coagulation against laparoscopic suturing. So, laparoscopic suturing is superior to the bipolar coagulation when you compare AMH or AFC at 12 months. And when you are comparing bipolar with hemostatic sealants is always preferred mode than using bipolar cautery. Okay. So, whenever you are recommending any patient for ovarian cystectomy, whenever you are managing the patient by ovarian cystectomy, how you should proceed? Yes, any doubt? Somebody's mic is on. Someone mic is on. I'm not able to see this. Please mute your mic. So whenever you are posting any patient for ovarian cystectomy, what are the precautions you should be using? So first of all, you have to do the preoperative ovarian reserve assessment, discuss fertility preservation options with her, perform pelvic ultrasound scan and bimanual clinical examination, obtain appropriate consent, and refer to a woman to the center of expertise if you think that the proper expertise is not available at your center. So which patient requires this preoperative ovarian reserve assessment? So the patients who have not completed their family, the ovarian reserve assessment should be done in following situations. So any patient who requires repeat surgery either on the same ovary or other ovary. Woman diagnosed with either severe endometriosis or bilateral endometriomas. Those with coexistent etiologies for subfertility, either male or female factor. Okay, like even low sperm parameters, that means male factor is also, if it is there, you have to do the ovarian reserve assessment. Any woman of advanced reproductive age and any risk factors for premature ovarian insufficiency. So all these patients, they should undergo ovarian reserve assessment preoperatively. Why? Because they are more likely to need ART for conception and they are at increased risk of POF or premature ovarian insufficiency. Ovarian cystectomy, it can reduce a woman's ovarian reserve, which will hinder the chance of IVF success. So now you are going to do this ovarian reserve assessment only for this high risk patient. Why? Because this ovarian reserve assessment, it predicts regarding the oocyte quantity, but it cannot predict regarding the oocyte quality. So for spontaneous conception in ovulatory couple, there is no need to go for ovarian reserve assessment. So in low risk patient, there is no need to go for ovarian reserve assessment because you cannot predict any spontaneous conception rates or oocyte quality with this reserve assessment. The accuracy of ovarian reserve assessment in the presence of ovarian cyst, it has not been well studied. So you cannot recommend whether to go for AFC, whether to go for AMH or other tests for ovarian reserves. Now for endometriomas, they have studied this AFC and AMH measurement, and what they have found out is AFC and AMH, they have been shown to be lower in presence of endometriomas, but they are not affected by the presence of other types of cyst. The AFC, it is reduced in ovaries with endometrioma, but finally, if the patient is posted for IVF, the median numbers of oocyte retrieved, it is similar between the ovaries with endometrioma and contralateral ovaries. So the AFC count may not be very well reliable in case of endometriomas also, because it can be missed because of large endometriomas. So after this ovarian reserve assessment, you have to discuss the fertility preservation options also with her. So if the ovarian reserve is already compromised or there is considerable risk of premature ovarian insufficiency, you should be discussing fertility preservation options. prior to cystectomy. Okay, so fertility preservation should be done prior to cystectomy. So for post-pubertal females, you can go for either egg cryopreservation or embryo cryopreservation following ovarian stimulation. It is an established technique that allows subsequent IVF or embryo transfer. But ovarian stimulation may be unsuccessful if the ovarian reserve is already compromised. And the disadvantage of this fertility preservation techniques before cystectomy, it includes delay in surgery, visceral injury during egg collection, pelvic infection from accidental puncture of the cyst, and theoretical increased risk of torsion of hyperstimulated ovary. Now coming to the funding, in UK, NHS funding is not routinely available for oocyte or embryo cryopreservation in case of benign condition. For malignancy, funding is available for this cryopreservation, okay, fertility preservation, but for benign condition, it is not routinely available. But if there is a considerable risk of permanent infertility, like previous oophorectomy or repeat surgeries in case of severe endometriosis, you can consider individual funding requests. It can be made through the clinical commissioning groups. So these are these groups, CCGs, clinical commissioning groups. They are there for individual trust and they can consider your request. Okay. So if you give the request for the funding, if they find it at it is appropriate request, they also can grant the funding for such conditions. Now, the third thing what you should be doing before any ovarian cystectomy is do the clinical and ultrasound assessment of that cyst. So you have to assess the type, size, and number and location of the cyst by doing ultrasound. Also, you will be doing bimanual examination, pelvic examination to identify any deep endometriotic nodules because it can be missed by ultrasound. Then you have to obtain appropriate consent. So in that consent, you should be explaining all possible risks associated with surgical procedure, including reduction in ovarian reserve and risk of oophorectomy. And if the surgery cannot be performed or completed safely, the patient should be referred to the expertise center. Now, whenever you are going for ovarian cystectomy, you must be knowing this ovarian blood supply. So ovary receives this blood supply from two sources. One is ovarian artery, which is directly branch of aorta, and then anastomosis between ovarian artery and ascending branch of uterine artery or tubal artery. So this ovarian artery, it is situated in the infundibulopelvic ligament, while uterine or tubal artery, it is found in the ovarian ligament. Okay, so ovarian artery, it is situated in the lateral ligament, that is IP ligament, while tubo-ovarian ligament, the uterine artery is there. And these intra-ovarian vessels, so these anastomosis, they are found in the anterolateral aspect of ovary at the insertion of meso-ovarium. So at the insertion of meso-ovarian, you will be finding this intra-ovarian vessel. So what is the applied use of this is, you should be taking incision on anti-mesenteric border of the ovary to avoid any damage to blood supply of that ovary. Now coming to the surgical recommendations. So you can see here they have divided the surgical recommendations for non-endometriotic cyst and endometriotic cyst. So they have divided in between these two. So non-endometriotic cystectomy, they are usually simple. You can see first give the incision on the anterior mesenteric border, anti-mesenteric border of the ovary. Then try to find out the cleavage plane. So you can do it by direct dissection or you can do it by normal saline dissection also, injecting normal saline also to find a plane. Now you have to dissect the cyst wall from that ovarian parenchyma and achieve hemostasis by targeted coagulation or by suturing. And then reconstruct the ovary. So this targeted bipolar application is very important. You should not go for randomized coagulation because it will damage the normal ovarian tissue. So this is for non-endometriotic cyst. Now coming to the endometriotic cyst, here you can see this is the first picture where there is a ovarian endometrioma is there and it is associated with the adhesions. So first you have to release the adhesion, mobilize the ovary and drain the endometrioma first. Take an incision on antimesenteric border, drain the endometriotic fluid, then try to again obtain a cleavage plane. But cleavage plane in obtaining in endometriotic cyst is very difficult. So here you have to use either vasopressin or normal saline. So here you can see the vasopressin is injected in this fourth picture. You can see this vasopressin is injected in the cyst capsule. So then you have to dissect the cyst capsule from the ovary. Then do the proper precise coagulation. Okay, so precise coagulation or dithermy use should be done to avoid any extra damage to the residual ovarian tissue. And after removal of large cyst, see, small cyst doesn't require reconstruction because ovary capsule gets approximated on its own, but large cyst they require reconstruction, so you have to reconstruct it by using sutures. And whenever you are suturing it, you have to place this suture inside the ovary, because exposed suture again it may lead to pelvic adhesions. Now for large endometriomas, you can go for two-step surgery. So what is this two-step approach is? So first, as I told you previously also, first drain the endometrioma. Okay. First mobilize the ovary, take incision on antimesenteric border, drain the endometrioma, and after the drainage of endometrioma, just inspect the cyst wall, take a biopsy for the diagnosis. Then abandon the procedure there only. Give GnRH agonist for at least 3 months to reduce the thickness of the cyst wall and also to reduce the vascularization. And then at a second stage, you can do the surgery with second laparoscopy. Either you can do cystectomy, CO2 vaporization, or bipolar dithermy or plasma ablation. Whatever you want to do, you can do in the second stage. So what is the here disadvantages? Woman has to undergo 2 procedures. But the benefit of this thing is that this may facilitate the management of larger ovarian endometriomas. It will reduce the recurrence rate and limit the damage to the ovarian reserve. So it can be a better approach for larger endometriomas. Okay. So this is regarding this ovarian cystectomy talk. Now, I think by next week, we will do another talk. Okay, that is another important talk is there, that is CA 125. Okay, so we will do that talk in the, I think mostly on Monday or Tuesday. So, bye for that time. Thank you for attending this. Bye.
Thank you.
Thank you, ma'am.